Good afternoon, everybody. I'm Debbie Lowry from KHI, and this has been such an exciting morning, and we're not going to disappoint you. We're going to have a great session this time, very exciting coming up, as well as the rest of the afternoon. So I want to thank you for attending the KHI eHealth Summit and for returning for the Integrative Premier Services session, also known as Platinum. So as you already know, because you've already seen it from the prior sessions, the video and the audio have been disabled, but please put any questions you have in chat. And if we manage to have a few minutes after the session, we'd like to try to answer some of them. So Brandon, you could go ahead with the introductory video.
Good afternoon. I'm Mark Spears, the Electronic Case Reporting Project Manager.
Can you turn it up a little?
Leadership team.
I'm sorry, it's not very loud.
I'm here to introduce the next session entitled Premier Integrative Services. Important healthcare data is at your fingertips inside your EHR systems, representing better healthcare outcomes as well as a significant time savings for clinicians. By adopting the IHE framework standards, providers can both send and query KHI from within the EHR to quickly access patient health information from multiple healthcare sources. The connectivity allows real-time access to aggregated clinical data, such as CASPR reports, if the user is credentialed, and Medicaid claims data. CASPR reports can also be accessed via the real-time clinical data in the KHI ePartner Viewer Provider Portal. Join Andrew Bledsoe, State HIT Coordinator and Deputy Executive Director of the Office of Health Data and Analytics, and Debbie Lowry, Onboarding Project Manager, for a lively discussion on the benefits of incorporating KHI data into your EHR. I hope you enjoy the session. Thank you.
Brandon.
Hello, welcome to the eHealth Summit. In this session, we will be discussing KHI Platinum and how it promotes health data interoperability. We will also discuss how KHI Platinum facilitates the exchange of accurate and comprehensive clinical data between healthcare providers and the Kentucky Health Information Exchange. In this session, we will cover the following topics: what KHI Platinum's IHE connections are and how KHI uses them, KHI's onboarding catalog for IHE, an overview of the IHE technical setup, and finally, we will demonstrate how Platinum connections allow providers to request real-time prescription drug information from KHI. KHI Platinum uses IHE connections and standards to integrate with other EMR or EHR systems. IHE stands for Integrating the Healthcare Enterprise, which is an initiative intended to improve the way computer systems in healthcare share information. By leveraging those standards and connections, KHI Platinum can be used to communicate and exchange data with healthcare providers. IHE was identified as a need because optimal patient care requires efficient access to comprehensive patient information. Systems that do not share information effectively may not have complete and accurate patient data. They may also create expensive rework and increased administrative burden. And finally, healthcare decisions are often made without the latest and most vital data for a patient. Platinum connections provide a framework to quickly and easily share accurate patient data, which creates an accurate and holistic view of the patient's healthcare history, improves efficiency by reducing administrative work, and facilitates more informed healthcare decision-making at the point of care. KHI's onboarding analysts work with the participant to rapidly onboard and establish the Platinum connections, such as XDS and XCA. Once those connections are established, participants can easily and accurately communicate patient data with participating organizations and provide vital patient information at the point of care. KHI Platinum uses standardized IHE protocols and transactions. This allows providers to connect to KHI quickly and easily. KHI uses ITI transactions to submit and query patient data, such as clinical documents, patient demographics, and the summary CCD. Furthermore, KHI is an XDS platform as well as an XCA community and supports transactions for both connection types. KHI's XDS connection supports patient identification through ITI 8 and ITI 44, clinical document submissions through the Provide and Register transaction, ITI 41, and queries for KHI's data using ITI 18 and ITI 43. KHI is an eHealth exchange and Sequoia-certified XCA community. KHI offers the Patient Discovery Query, the Cross-Gateway Query, and the Cross-Gateway Retrieve Query. This means our XCA participants can check for a patient's medical records with KHI as well as any of our multiple XCA community partners. In other words, these transactions and connections allow KHI Platinum participants to request and retrieve available on-demand and stable documents for a patient from KHI's database as well as other XCA partners. KHI then compiles the available documents and delivers them directly to the Platinum participant's own EMR EHR system. This means providers can receive and view CCD documents, including the Summary CCD and the Medicaid CCD, in their very own EMR system. Once these transactions are processed in KHI, users get access to real-time clinical data from multiple healthcare sources. This data includes stable and on-demand clinical documents, Medicaid claims data, KHI Summary Continuity of Care document, and Prescription Drug Monitoring Program PDMP data and reports. By providing access to PDMP data, KHI Platinum is enabling providers to combat the opioid epidemic in Kentucky. KHI is connected to CASPR, which is the Commonwealth of Kentucky's prescription drug monitoring system. The Platinum connection can retrieve CASPR data in real time. Participants can use the Platinum IHE connection to query KHI for the latest PDMP data. This data is essential because prescription drug information sharing strategies are an important part of combating the opioid epidemic and prescription abuse. In addition to the Platinum IHE connection, KHI supports National Council for Prescription Drug Programs (NCPDP) queries and PDMP access through the ePartner viewer for authorized users. By having access to this data, clinical workers are better informed about the prescription drug history of a patient and can make informed decisions when prescribing medications. By using services like KHI Platinum to retrieve real-time data, Kentucky's healthcare providers are better equipped to address the opioid epidemic on the front lines. To summarize, KHI Platinum is a method of transmitting real-time clinical data to KHI using IHE standards and connections. It allows KHI to provide quick and easy access to patient health information from multiple healthcare sources, such as other hospital systems, pharmacies, and clinics. It also helps providers at the point of care make more informed decisions.
This has been a presentation about the capabilities of KHI Platinum's IHE connection. Thank you for watching.
For some of us, pictures speak louder than words. So as she just said in the video, as a provider, you can input your patient data into your EHR, EMR, which flows into KHI and allows it to be disseminated to other providers, as well as you can then query for the needed patient information from all provider sources through your EHR and KHI. It is now my honor to introduce our speaker, Dr. Norman Stone. He's an orthopedic surgeon at the Joint Base Andrews. He's also a clinical informaticist. That's a hard word to say, unless you're used to that one. I'm struggling with that. With the Federal Electronic Health Record Modernization Program Office. Take it away, Doctor.
Hi, good afternoon. Thanks for that. Are you able to hear me there?
Yes.
Okay. You know, I lost my my personal video here. There you go.
Well,
Start
yeah,
that.
there you
There
are.
it is. There it is. Good afternoon, everybody, and thanks for participating in this in this session. You know, I was asked to come by and see if I could relate a little bit about the Defense Department's experience with integrating external data and documents into our primary EHR system, and give kind of a clinical perspective on that. So I'd like to get there with some screenshots, and time's a little bit short on this session, so we're going to kind of move a little rapidly. I promise we'll get to some screenshots there. I don't want to imply that we have this all figured out and hey, this is the way to do it, because in fact, you might have heard that we're in the midst of a 10-year, multi-billion-dollar replacement of our electronic health record systems with primarily a Cerner-based foundation. So let's move on through this, if you don't mind. This is one of my favorite slides to put up there, because I think it captures kind of what goes on in a lot of hospitals and clinics. Is docs and clinicians, we get upset about stuff, but we don't do a great job always of relating that to folks who can make a difference. So I think we're all here to kind of to improve either the individual person in front of us, or the system, or our facility, whichever level we're operating at, and to get healthcare to a better place. So as I was thinking about how could I get to these topics with you, I thought about, well, we're in this period of holidays and lights and Thanksgiving. So I thought, maybe a food analogy would help get to where I'm going. So, if you're the chef in your kitchen there and you're preparing a meal, you have to get things out of your pantry. And a lot of pantries look like this. So your task when you're preparing the meal is you have to dive into your pantry. If you've got to find the ingredients that you need. If you're making spaghetti and meat sauce, you've got to find the tomatoes and the tomato sauce and the garlic and everything else. Hopefully it's in there, but if your pantry looks like this, it's really going to be tough for you to find that, I think. Moreover, you're there in the kitchen, and you have, every time you need an ingredient, you have to truck your happy self all the way down to the pantry over there, shuffle, rummage through to find what you need, and then, shuffle yourself back to the kitchen where you can use it. And I think this analogy is appropriate for how we handle external health data in a lot of systems across America today. So if we're in the analogy of the cooking and the chef, the questions that you might be asking yourself in your pantry are, hey, where's the tomato sauce? Is the spaghetti gluten-free because someone has an intolerance? Or do we have the ingredients to make garlic bread? Those are typical. But I would argue that there are similar questions happening in the clinic, as you probably know. But those are more things like, what did the EKG of this patient look like last year? Are those T-wave inversions old, or are they new? Did the neurologist's EMG or NCS that was done 3 weeks ago, did it show carpal tunnel syndrome? Or something more proximal up at the elbow or the neck? And other ones, a little more complicated ones that we should move towards are, which blood pressure medications has this person tried in the past? And then maybe even correlating that with blood pressure over the subsequent months to get a sense for which may have worked and which might have not. So that's where we're going to return to this cooking analogy towards the end there, but it gets me to one of my first points I'd like to go home with. And if you could spend some more time with your physicians. Now, I don't think that I think there's a lot to be gained on their end and perhaps on the administrative and IT end. It doesn't have to be an all-day laborious, block your whole schedule. It can be an hour or two in clinic. And what I'd suggest you do is just go there and look for patterns. Look for patterns of questions that the physician's asking. Look for patterns of behavior where they're hunting and pecking to find things. I think it'll help illuminate. It's been one of the best things I've done in my practice, is bringing in the administrators into the operating room and places like that. So that's one point. The second point there I want to get to is communication. And I think we all sort of intuitively know this. There's a great activity, and the social determinants of health are coming to the fore in the last couple of years. This group, GoInvo, a design firm in Boston, has this more broad description of all determinants of health. And I think it's fantastic. But even one thing it misses, though, is communication and the availability of information to the provider. This is very much a patient view. Now, we know that communication is important. This is Joint Commission data, looking at the number one root cause for sentinel events over many years. And communication is always near the top. And when you break it down into the type of sentinel event that occurred, communications at the top, communications at the top for elopement, post-op communications, over and over and over for each of the primary ones. Communication is the top there. I don't think it's a surprise to anyone on this call, but I wanted to make that point. And likewise, in addition to the sentinel event patient safety world, there's also been described the element of communication from a malpractice avoidance world. And this group, the reference is in the bottom again there, if you want to look at it. These are some of the EHR-related communication questions, like, are you concerned that the information you just put down in the EHR is not getting received by someone else? Or the third one down there, have you ever been unclear why you were seeing a patient in consultation? I've had that happen in my civilian practice. Patients come in and they're kind of like, hey, I'm here, and they don't really know why they're here. When you don't know why they're there either. Is it an elbow? Is it a wrist? Is it a knee? Is it a hip? And I guarantee you the physician who sent them in had a specific question, but it's just not available at the point of care. This group looked at malpractice cases, and they found 7,000 cases of 23,000 that they reviewed where communication was a primary issue that led to the settlement or award. Okay, and that was a total of those 7,000 cases of $1.7 billion in incurred losses. So it's a communication factor is a substantial thing. I won't belabor that. And of course, that's take-home point number 2, not a surprise. I'd like to talk, I couldn't have a talk without at least one slide on usability. Usability refers to how easy it is to use the system in front of you. The human-computer interface is one of it. And we often get things that are like on the left side of the screen here. This is a medication list that could be from any EHR. Many of the vendors have improved them, and I would like to encourage you to push your vendors to improve the usability. So we can move towards the center of this screen here, where now the medication name is boldface, and the less important information from a day-to-day basis is sort of grayed out, but there. Then you move over to a more detailed view where it tells the physician, these are the pill sizes, and then these little blocks, which if you see down here, this tells the physician how close to the upper dosing limit are you for that? And these are common clinical questions. What medications can I add to help the blood pressure, to help the diabetes management? And little subtle clues like that tell you how close are you to the ceiling for the medications are very helpful. Again, the reference is in the bottom there for this great group. And please push your vendors to improve the usability. Advocate there, right? So now let's get to what we're doing in DoD. I have a few screenshots here of our current state, and then a few screenshots of what we're moving to with our Military Health System Genesis, MHS Genesis program, which is the name of the software suite that we are deploying across all of our clinics and hospitals around the world. It is primarily, at the core is the Cerner Millennium and its associated suite of software, but it also includes many other components. For example, the Dentrix application from Henry Schein. So when we're in the clinic in the DoD, the primary system we're looking at is what we call Alta. And this is a screenshot of Alta. Very clearly, it is not what we would consider a modern user interface. But this is what we're looking at. And very nicely over the last 10 years, I think with some nudging from Congress, we have developed what's called the Joint Longitudinal Viewer. And if you see in the lower left corner down there, when you're in a patient's record, you'll have this little JLV link. And if you click on the JLV link, it will bring this up. And this screen over here in the main part of the screen is an integrative view of that patient, and each of these little windows, modules, or widgets as we call them in JLV, are movable left, right, up, and down. You can take several away and add other ones in there. Our case managers do that a lot. They'll put in ones that are much more appropriate for their line of work. And people like me will put in things, notes and external encounters. This particular patient doesn't have any external encounters. They're all, if you look, you see all yellow or orange dots here, indicating that these are all DoD sourced data points. But this demonstration patient here does have some external data. So if I click through a few slides here, this is the immunizations, for example, and you can see we're pulling in the immunizations data from Unity Point over there. And then over way on the side there, allergies are being pulled in from other facilities. Now, this is a test patient, obviously, but our live patients do the same thing. One thing I will point out is this is not integrated in our EHR. It's a window that opens within our primary EHR system. What would be ideal is to have those immunizations already folded in, integrated one by one with the immunizations provided at the DoD clinic. Likewise, the allergies, likewise, the notes, the lab results. The commercial EHR vendors out there, the big ones being Cerner and Epic, they're doing a better and better job of this. In fact, I have a story that I tell sometimes about working at one Epic-based hospital where I didn't order a new type-in screen because I saw that the patient already had one earlier in the day. And that patient had been transferred in, though. And so when we needed to order blood for the patient, I said, well, they have a type-in screen. And actually, they don't. The type-in screen was at the other hospital, and to do the type-in cross, you actually need the blood sample. So we had to, the data was so integrated, I didn't even recognize that the type-in screen had been done at the other facility before transfer. But I do want to point that out. This is not our ideal situation. It's our current situation. It is much better than no access, and it is much closer to our EHR. We don't have to go log on to a different system or deal with a pop-up window or other credentials. So it's a great step forward, but it's not where we want to be, I think, entirely. So moving back forward, we also have another external interoperability system called HAMES, which I won't get into right here. It is very much for getting X-ray images in, as well as scan documents that have been returned. We can talk about that another time if need be. Here's what we're moving to, and I suspect a lot of the attendees today have Cerner as their EHR. Epic has very similar screens, and I suspect the other major vendors do as well. This is what Cerner calls its community view, and it's very similar to our JLV, where it has integrated modules, and they're pulling in data through their Healthy Intent platform from different sources that you can see listed over in the source column here. Now, they've gone a step further than what we have currently in DoD. And that's part of the reason why we're deploying it. Now, if I flip to the next slide, what we see here is a patient's chart as you are meeting with them in the clinical exam room. You go top to bottom through their major medical history sections: allergies, current medications, past medical history, past surgical history, those core things. And you'll see up in the top right corner, these slides literally arrived to me 10 minutes ago, so I apologize that they have not been highlighted. But you'll see this reconcile button up here. And what that indicates is that this patient has external data, which is available for the clinician to go out, not only to view, but also to hit add and merge that into the chart so the next person will see it in line here. And here's what that screen looks like. So here, now we're in the reconcile mode, and you can see over on the right-hand side of the screen here, the item or the data that we're talking about, like cardiac ablation here, for example, and where it came from, Healthcare Access San Antonio in this case, the date that it was modified, and we have the option here to add or to discard. And when we hit add, that item gets folded in to our the Cerner Millennium, our internal EHR, making it visible in line with for all future review opportunities. And as I understand, it keeps information in there that refers to the official provenance of that data point. So this is what we're moving to right here, the Cerner Millennium-based platform. Again, I can't say that Cerner has got the grip on this thing. I suspect Epic and everybody else is doing something very similar, and I'm so happy that we're starting to get to this level. We've been talking about it for 10 years, and now we're getting there. So I would like to say that there's still more work to be done, not a surprise to anyone. And I'm back to the pantry for a closing slide or two here. So we have the messy pantry. Okay, and obviously the analogy with going to search for external health data is pretty clear, I think. Now, if we can organize the pantry, that's a much better step in the right direction. But here's one of the things that I hope your interaction with your physicians will bring out to you is they are not making a full menu of 30 or 40 different recipes each day. They are making the same 1 or 2 recipes 20 times per day. So if you were making spaghetti and meat sauce 20 times per day, and you had to go into your pantry to retrieve each item, each ingredient, okay, and make it 20, you would be pulling your hair out. You'd look like me, okay? So in those situations, maybe it's better to pull the spaghetti and meat sauce items together in the pantry, maybe pull them out of the pantry all at the same time. Or if you're really making it 20 times per day, maybe you store them on your kit in the kitchen, maybe even on the countertop in nice bins, okay? And I think that this cooking analogy really gets to what we as physicians are experiencing in a lot of cases with get retrieval of external data. We're on the cusp of being able to get it more integrated. And so to the extent that you're able to advocate for that in your organization, I think you'll have a lot of happier physicians if you can get us to the next level. And after that, let's not be happy there. Let's go to the next level. I think that brings me to the end of my prepared slides. And I think we're getting kind of close on time. So can I hand it back over, you think, Deborah, and you can coach us as to whether there's time for questions or comments? And Deborah, you might be on mute still if you're talking. We can't quite hear you.
Yes, you're right. I am on mute still. I don't know.
I think I'm reading 1:59 p.m. So we might have just barely made it over the carrier deck for this landing. Not sure if there's time.
That's okay. It was a great discussion. We don't have any chat questions, but
Great.
I definitely want you to show me how to do that pantry.
Yeah, that wasn't my pantry.
Because my pantry is nothing like that. We want to give you a sincere thanks for coming and talking with us today. It was absolutely wonderful. You've given us a lot of things to think about, and you've showed us some great things with your slides. I bet we want to invite you back another time because you kind of alluded to that. So that was pretty good. That was a good segue. I want to thank everybody else for participating in this particular session, but it's now time to move on to the next session, which is the 411 on how to connect. Thank you all. Thank you, Dr. Stone. Bye.